We will get started. This is the perinatal harm reduction section. My name is Joelle Puccio, they, them, theirs, or AA if we're speaking Spanish. I have been a perinatal nurse since 2004. I have been a travel nurse for 7 years. So I worked, I think needs to be updated. I think it's now 16 hospitals in 9 states or something like that. I'm no longer travel nursing. I'm now settled in Arizona. I am volunteering with a local syringe access program. I'm working as a nurse at a facility that only cares for infants with opioid exposure and their families. And I'm also the director of education at Academy of Perinatal Harm Reduction. I've been doing this work for a really long time. I think the first time I presented was in 2014. Also, it might be like my 10-year anniversary. That's fun. Um, but basically, I've been studying this for a really long time, and I'm just really excited to share what I've learned with everybody. So at the Academy of Perinatal Harm Reduction, our mission is very broad. We aim to improve the lives of pregnant and parenting people who use substances. Our particular piece of that tends to focus on education of people who are pregnant, their caregivers, their loved ones, their service providers, staff trainings, putting out resources, posters, all kinds of different formats of information, because we believe that information is power. And we also understand that even if someone might have some kind of formal medical training, they probably didn't receive very much actual training on substance use in the pregnancy period. And if they did, it was probably not terribly accurate. And I can say that from experience. In nursing school, we got no training on this, not once. And we talked about substance use in general for only about 20 minutes. So we really think that everybody needs to have access to the same information. And we also reject the idea that people who use drugs are somehow incapable of understanding this information on the same level as someone with formal training. We understand that pretty much everyone approaches this at the same level of knowledge, or perhaps a better description is at the same level of dis and misinformation. Our goal is for families to be safe. That's always the number one goal. We also want those families to be intact, meaning not torn apart by state kidnapping of their children for the silly reason of what the contents of their urine is. And the QR code on the screen will take you to Pregnancy and Substance Use, a Harm Reduction Toolkit, which is a resource that we put together with the National Harm Reduction Coalition. First came out in 2020. The current version was updated in 2022, and we are working on something new for release early next year. That QR code will take you to all the versions. We also have a couple different state versions in addition to the national one, and a couple other countries have their own version as well. If anybody is interested in making a version for your locality, please reach out to me. I would be super excited to talk about that. That can be a DIY project that costs your organization $0, or it could be whatever you want. We could do a multimedia blitz and the whole works. So just let me know if anybody's interested. Unfortunately, I don't have any financial relationships to disclose. I'm not against it. Get at me. Before we get into this, I want to pause and talk about the content, especially since this is a peer association. I want us all to just acknowledge that these topics are really heavy for a lot of people, especially people who have personal experience of substance use while pregnant, people who have experience of a parent using substances, people who have been told all their life that they're somehow broken or damaged because of their substance use. I'm here to tell you, you are not broken. You're not damaged. You are worthy, and I'm super excited that you're here. If this content gets heavy or you start having physical or emotional reactions, please step away. I won't have hurt feelings. This is being recorded. You can come back to it if you want to. I just want to make sure that we're all looking out for ourselves and for each other. I've also been told that, especially when I present this content to peer audiences, that folks need some time afterwards to process and think. So if you're planning to go straight from this to something else, maybe leave a little bit early, maybe make some plans for how to take care of yourself. All right, having said that, let's start talking about genocide, right? So I like to do an Indigenous acknowledgement when I'm presenting in a location. Since this is a national and virtual one, we're just going to kind of talk about the intersections between harm reduction for people who use substances and the genocide they're experiencing at the hands of our government, and harm reduction for Indigenous people about the genocide that they are and have been experiencing at the hands of our government. So when I say genocide, I'm not being hyperbolic, I'm not exaggerating. The United Nations defines genocide as preventing births, forcibly taking children from one group and giving them to another group, causing death, mental or physical injury, or inflicting poor living conditions. And all of these things are things that have these are tactics that have been used by the government to oppress people who use drugs. There's so many intersections with the genocides of Indigenous people and Black people and other people of color in our country. And oftentimes, drug use is used as an excuse to inflict these genocides on these groups that our government finds undesirable. If you want to learn more about Indigenous genocide and the way it intersects with pregnancy and with substance use, if you just look at one resource on the slide, I would recommend season 2 of This Land, the podcast. They go over the Supreme Court case last year, which upheld the Indian Child Welfare Act, yay, Holland v. Brackeen, in really, really great detail. One of my favorite lawyers said, if you listen to this podcast, you will understand more about Indian law than most Supreme Court justices. So if that's not a ringing endorsement, I don't know what is. If you want something a little shorter, you can check out season 3, episode 3 of Reservation Dogs. This episode is called Dear Lady, and it's about the so-called schools that Indigenous children were forced into when they were stolen from their families. The last of these, by the way, closed in the 90s. So it's not like this is some ancient history we're talking about. People my age were forced into these work camps, basically, as children, as young as, 3 or 4 years old. There's a lot more that can be said about this, but we'll move on. We can talk more about it later. Oh, and I forgot to mention, if anybody, since we are such a small group, if anybody has questions, please just stop me or put it in the chat. And Casey, if you can let me know, because I can't do 2 things at once. Or come off mute and just interrupt me because I want to make this session work for you. So I think everybody here knows what harm reduction is, but I just like to kind of go over what it means to me and a couple points about recent events. So harm reduction is a way of life. It's many things. It's an overarching way of looking at the world. We all do this in our everyday lives. I don't think there is a single person who hasn't done some form of harm reduction, right? Um, and that's why I think it's so problematic that people and organizations and governments that are new to harm reduction, excuse me, they position it as a pillar next to, abstinence-based treatment and next to all of these other things. But harm reduction is not distinct from or opposed to any other intervention or treatment modality or response really to substance use or problematic substance use. Harm reduction encompasses all of that. So abstinence is harm reduction. Safer use is harm reduction. Reduced use is harm reduction. Having better policies is harm reduction. Anti-capitalism is harm reduction. Anti-racism is harm reduction. All of these things that we're doing in our everyday lives to make the world a better place are harm reduction. And so it's really important that we don't make it smaller than it is. So harm reduction interventions. We've all heard of the seat belts and driving in cars and painting lines on the road. And I really like the driving analogy because we can think about it in terms of like, what is something the individual can do? They can put on their seat belt. What is something that we can do to make the environment for the individual safer? We can paint lines on the road and we can have traffic signals. What is something that we can do on a policy level to make people safer? We can provide public transportation. We can make sure that car seats are available and that they are safe and that people know how to use them. So even though it's kind of an old cliche, I think it really works because we can find examples on every level of what we're talking about with reducing harms and just coming at this topic from a really practical perspective. So when we're thinking about pregnancy, somehow our harm reduction brain hits a glitch or something. We're really accustomed to thinking about people who use drugs as having their self-efficacy and having the right to control their own body, being an adult who's capable of making decisions for themselves and their family. But in our culture, when we think about pregnancy, all that stuff kind of goes out the window. We're accustomed to having opinions about what pregnant people should and shouldn't do. We're accustomed to legislating those opinions, which are often uninformed and inaccurate. And so it's important when we think about pregnancy that we center that this pregnant person is also an adult who's fully capable of making decisions about their body. This is also somebody who has self-efficacy and who has a right to bodily autonomy. We also need to look at the whole picture, which is another thing that we kind of have a hard time doing when we find out someone is pregnant or has small children. We tend to want to zero in and focus in on those children as if their interests are separate or even in opposition to the interests of the parent. So when we're thinking about how do we reduce the harms, we are thinking about not just medical harms. We are thinking about how do we reduce the harms of unequal pay for women and people of color? How do we reduce the harms of pollution in our neighborhoods? How do we reduce the harms of food deserts, of punitive and even criminalization interventions aimed at these families? So one thing that medicine has really missed the mark on, like forever, but they're starting to sort of pick up on it in recent years, is that people are whole people. When we're looking at somebody who is not gaining enough weight during pregnancy, we don't just waggle our finger and say, you need to eat better. We dig into it. Like, do you have access to food in your neighborhood? Can you afford food in your neighborhood? Are you accessing, WIC and SNAP and all of these things? Because so many of our health problems, I would say the vast majority of our health problems are not really coming from medical roots. They're coming from the social determinants of health. And so that's what we need to focus on with pregnant people, just as we focus on that with everybody else. So I kind of hinted at this a little bit earlier, but one thing that's been really helpful as a framework to think about the pregnant person and the fetus or the baby after it's been born is that they're not distinct individuals with distinct needs and even opposing needs. So I love this quote from all the way back in the 60s. There's no such thing as a baby. If you set out to describe a baby, you'll find you're describing a baby and someone. A baby cannot exist alone, but is essentially part of a relationship. So when we're thinking about what's in the best interests of the baby, which is something I hear all the time in my work as a nurse, well, I don't care about the mother, I only care about the baby. You can't, that's not a thing. You can't do that. When from the moment babies are born, all they want is to be ideally back inside that person's belly. But since that's not possible, all they want is to be close to that person. We know that being close to the birth parent in the hours, days, and weeks after birth has just amazing and permanent effects on both the birthing person and the baby. We see stabilization of blood sugar. We see improved weight gain. We see all of these benefits for babies, as well as reduced risk of mental health issues for the pregnant person or the birthing person, less bleeding after delivery. Like it just runs the whole gamut. These two people need each other so essentially and so intrinsically that they cannot really be separated. The needs of one are the needs of the other, and they are each other's best medicine as well. So let's look at a little bit of data. I promise we're not going to talk about that much data. This is from the National Survey on Drug User Health, which I think it's a real missed opportunity. I've heard some researchers call it NS-DO. NS-DUH is way better because if you've been paying attention, most of the results from this survey are like, well, yeah, duh. So we know that people use drugs during the same part of their life that their reproductive years are happening. So when we look at somebody who is pregnant and who is using drugs, oftentimes people have like this knee jerk, oh, well, she shouldn't be doing that. How could she possibly make a choice to become somebody who is, injecting fentanyl 15 times a day while pregnant? And that's not really what happens. What happens is that these two life courses intersect. So we're looking at somebody who didn't mean to become somebody who is chaotically or unhealthily using substances and happened to become pregnant during that same time. Another assumption we make is that people who use drugs don't want to get pregnant, don't want to have children. And that is really offensive. People who use drugs are just like the rest of us. They have reproductive goals, they want to have families, and oftentimes these pregnancies are intended. However, I think some of the data that we have is a little bit skewed because people are ashamed to admit that these pregnancies are intended, or their providers just assume that they're not intended. Anyway, that's a whole other side story, but we won't get into that too much. The main point is this is a time when people use substances. So on the slide, you can see between the ages of 16 and 39, that's when most people are using substances. And that is also when most people are most likely to become pregnant. We also know from the same survey that most people dramatically decrease the amount of legal and illegal substances that they use during pregnancy. So we can see, we'll look at these a little bit separately. The graph, the four bars on the left are for alcohol. So we see that non-pregnant people with the capacity for pregnancy, roughly 55% of them drink alcohol before becoming pregnant. Once somebody is in their first trimester, which that's for many people, they don't know they're pregnant until about halfway through their first trimester. So the dramatic decrease that we see in alcohol use in the first trimester is likely mostly because of people who are trying to get pregnant and stop using alcohol. Then once pregnancy is confirmed and we see the second and third trimesters, those rates of alcohol use are very, very, very low. So they've gone down by about 90% from non-pregnant rates. And this is typically just what people are doing on their own without any like formal interventions or services. When we look all the way over to the right at illicit substances, we see that the pre-pregnancy rates are quite a lot lower, just over 10%, and kind of the same pattern as we see with alcohol. Not a huge difference in the first trimester before people recognize their pregnancy, but then we see significant decreases in second and third trimester. Now, when we look at cigarettes are kind of the outlier for substance use during pregnancy. We see that non-pregnant people, about 25% of them use cigarettes. And then we see a very small decrease in the first trimester, again, probably related to people trying to cut back or quit when they start trying to become pregnant. And then we see that kind of stubborn second and third trimester where we do see another drop, but not a very big one. So it's just about 50% drop as compared to like that 90% drop for alcohol, which kind of drives home the kind of well-known axiom that cigarettes are the hardest thing to quit. And that is borne out by the data in pregnancy in this case. So I want to talk a little bit about why it's so hard to apply harm reduction to pregnant people. I think when somebody becomes pregnant, like I talked about before, we tend to kind of infantilize them. We tend to make assumptions about what is a good woman and what is a good mother. And we kind of think that they should care less about themselves, so we sort of care less about them. And when you really start to break down these ideas and think about them critically, they become pretty absurd. And also, like, once you see it, you can't unsee it. So what we end up with is a culture in harm reduction even, which is changing in recent years, but especially back when I started, we just see people in harm reduction being like, oh, well, we're not here for pregnant people. They need to just stop. The abstinence is the only thing that's allowable or acceptable for pregnant people. And a huge part of that is just because of misinformation, which we're going to talk about a little bit later. But another huge part of it, I think, is from our roots in harm reduction. We know that women, trans women, women of color have been the backbone of literally every social movement ever. But we also know that in harm reduction, white gay men were more at the forefront. They were the ones that tended to be on TV and in these prominent positions. So we have kind of this culture of not really focusing on reproductive health and the needs of women and other people with the capacity for pregnancy in harm reduction. Most harm reduction programs that have a reproductive health program will do like HIV testing and condoms, which is fantastic. I love both of those things, but that's far from a comprehensive harm reduction program. I've heard I've talked to a lot of folks that are like, oh, well, we can't really afford it. We only provide essential things. But you know what? Tampons and pregnancy tests and Plan B pills, these are essential things for 50% of people in the world. And so we need to start paying more attention to those people. So we end up with drug policy in the United States that is often that deputizes literally everybody. So we have healthcare providers who are collecting evidence against their own patients. We have social workers who are collecting evidence against their own clients. We're just accustomed to this type of surveillance, so that even when I talk to people who use drugs, about some of the violations of their privacy and their human and civil rights, it's normal. They're like, wait, that's not just how it is. That's not just normal. It has become so normalized that we don't even see it anymore. So I encourage you all, as you go back to your normal lives, to see it. Look for instances where we are just expected to deceive, to lie, to coerce our clients and our patients and our community members when they come up to us asking for help, which is what has happened to so many in the medical field, including myself. This is one of the hardest parts about working in this field, is having to choose between working in this field and participating in some of these atrocities or not working in this field at all. And it can be a really, really difficult issue for those of us like yourselves who do service provision, is how do we do good service provision within these systems that are forcing us to harm our clients and our patients. And one of the ways that I like to focus on that is incremental change, but every incremental change we make should be pushing us towards liberation. So that means that if your local police department comes to you and they want to get funded for doing Narcan trainings or something, we think about that critically. Like, yes, we want our first responders to be trained in Narcan, but does that training need to increase police budgets and increase the public perception that police are appropriate responders to a health crisis? No, we can train the police to deliver Narcan through a community organization where they are not centered and their budgets are not fattened any more than they already are. So that's just kind of one example. I want to talk a little bit about mandatory reporting. This is, most people have probably heard of this. There are several laws about child abuse, elder abuse, a couple other things where people in certain professions are required to file a report with a government agency if they suspect that such and such is happening. The laws about mandated reporting are not consistent across the states and territories in the United States. And they're quite confusing. And I've never met anybody who wasn't like specifically passionate about this field, who was like a doctor, a nurse, or social worker who was adequately familiar with the laws in their state. So make yourself somebody who is familiar with the laws in your state. Most states do not require testing or reporting of infants or pregnant people who are suspected of substance use or even who are testing positive for substance use. There's all kinds of different cutouts here and there. For example, in Arizona, where I am, we don't report people, well, we're not required to report people who are using their methadone or other MOUD as prescribed, and we're not required to report people who use cannabis. However, that still happens. Like I've never seen it not happen. So but it's important to know what these laws are because then you are armed to push back when mandated reporting oversteps. And it's really important to do that because mandated reporting seems like a good idea, right? If we're worried about somebody, then there's an avenue where we can report that. However, what we see when we look at mandated reporting is a lot of problems. Firstly, it does not catch every child who is at risk, and it catches a lot of children who are not at risk. We also see mandated reporting used in a retaliatory fashion, both by, family and community members and neighbors who have a beef with you because you don't mow your lawn, so they call CPS on you, or even with healthcare providers. It's super, super common when the patient tries to say, hey, I don't agree with the treatment plan for me or my child. I want to try this other thing, for then a retaliation report to be filed. So we see that these reports, they also tend to massively increase after a publicized child abuse incident, which causes, and it ends up being like 98% of the reports are unfounded. So it really takes resources away from what we want to be happening. We want children to be safe. We want children who are truly at risk to be safe. What we don't want is for thousands of people to be reported, investigated, separated from their children over these unfounded false allegations. We also know that in many states, in only a handful of states is it required to report people just for a positive drug screen. But in all states, that is the norm. That's how people operate in hospitals and schools and other places where people interact with service providers. And so excuse me, I lost my train of thought for a second. I just want to reinforce the idea that mandated reporting is not the answer. All of the data that we have on it shows that it uses too many resources and does not really have a payback for that. So check out the If, When, How resource there. It goes over the laws and specifics in every state and territory. And it's not super long either. Like your state section will be like this long. So it's a really, really nice resource. So when we're talking about pregnancy in general in the United States, it's important to note that it's dangerous. And when we have substance use in the mix, we tend to see this knee-jerk reaction, not just from doctors and policymakers, but from pretty much everybody in our culture. We think, oh, well, if something bad happened during this pregnancy and the person uses substances, then it must be because of the substances. But it's important to note that poor outcomes happen to a lot of people in our country. There's some numbers up there about maternal death and overdose death. So we know that the United States has roughly 3 times as many of both of these deaths as other Western countries with developed healthcare systems. And that number has been going up quite dramatically. Our maternal death rate has when I first made this slide, the number was 13. So, and that was about 10 years ago. So it's gone up quite dramatically. And that is driven particularly by overdose and mental health related deaths. When I started in nursing, our number one causes of maternal death were cardiac related. So it would be like high blood pressure events, like strokes or bleeding and hemorrhage, things like that. But now those have been surpassed by overdose and other mental health issues. We also know that our overdose death rate has skyrocketed in recent years, and it's important to think about how these two statistics intersect for somebody who is oppressed both as a pregnant person and as a person who uses drugs. So in our toolkit, we do a deep dive into 6 different classes of substances. So I encourage you to check that out if you're interested, if you serve people who have the capacity for pregnancy. Today, because of time limitations, we're only going to talk about tobacco and nicotine. I chose tobacco and nicotine because other than alcohol, this is the substance that we have the strongest evidence for the most severe and the most permanent harm. You heard that right. Tobacco and nicotine are much more risky than any of the other substances as far as permanent and severe harm. All of these outcomes on the list have pretty strong data linking them to cigarette smoking in particular. I want to make that point. We don't have a ton of data about other forms of nicotine, such as like patches and gum and vaping, but we'll get into what data we do have in a couple slides. But most of this information is related to cigarette smoking in particular. So when we're thinking about harm reduction for nicotine, of course, as with most drugs, quitting altogether is the safest choice, both for future health of the birthing person and for the pregnancy outcome. However, we do have a little bit of information on gum, patches, medications like Wellbutrin used during pregnancy. Most of this data, at least in the beginning, was collected from people who were on these medications or treatment modalities when they became pregnant. They seem to have adequate pregnancy safety. However, they are not approved by the FDA for use in pregnancy. But if you look, the list of drugs that is approved by the FDA for use in pregnancy can be counted on one hand because we don't study drugs in pregnant people. So don't let the lack of FDA approval bother you. Like, Tylenol and ibuprofen, like nothing that we use in pregnancy is actually approved for pregnancy. So we know that as similar to other substances, quitting altogether tends to be the safest for people's physical health. Mental health should be part of the risk-benefit analysis when you're looking at that. In some situations with some drugs, quitting might not be better overall if it's going to have significant effects on mental health. Quitting with traditional therapies that have been tested, that have been used for decades in this population is considered safer. Quitting with a vape is probably similarly safe to some of those other therapies, but we don't have that long-term data on it yet. And then, of course, least safe is continuing to smoke cigarettes, which I think is a kind of obvious, but also really important point to make because I have somebody close to me when they were pregnant, they were told by their OBGYN not to quit smoking cigarettes because if they started vaping, they would probably be ingesting more nicotine than if they just continue to smoke cigarettes. So that may or may not be true as far as the nicotine consumption, but it's not relevant for a few reasons. Firstly, for adults, we know that most of the harms associated with smoking are related to inhaling smoke, not necessarily to nicotine. Nicotine is, it's a chemical that is found naturally in a lot of, like it's in eggplants and stuff. It's not particularly bad for somebody. I wouldn't say that it's perfectly safe, but on the list of like substances that one could consume, it's kind of meh, you know? The real problem with cigarette smoking and tobacco smoking is inhaling those products of combustion. at least in the short term. But we also have to think about the long term when we're counseling people about quitting nicotine. If my friend, when they were pregnant 10 years ago, had been encouraged to quit or to try different modalities, the combined support of being in care, having regular appointments with a doctor. When you're pregnant, you have more doctor's appointments than any other time in your life. So having that regular support could have helped their quit attempts be more successful. They could have also tried a few different things. They could have vaped. This might have been a capturable moment of motivation where this person could have changed the trajectory of their life, and maybe they wouldn't still be smoking cigarettes today, 10 years later. Maybe their kid would be growing up in a smoke-free home and car. There are more benefits to think about when we're assessing harm reduction interventions for pregnant people than just pregnancy outcome. And that's another thing that we kind of absorb from our culture. Everybody's very interested in the pregnant person until the birth happens, and then we're like, good luck. So I want to make sure that we in the harm reduction community are not doing that we're thinking about the whole person, the whole family, and the whole life course. So a little bit more detail about vaping safety. I have a few references down at the bottom there. I can give you full titles if anybody's interested in doing a deeper dive. But I am here to say it is not controversial. It is established. E-cigarettes are safer than combustible cigarettes for everyone. That is not controversial. And I know that our public health messaging in the United States may have misinformed a lot of folks. And there's a lot of reasons for that, but I don't want to go over time. Let me just say it is safer. That's not debatable. All of those resources at the bottom are studies on pregnant people, but there are similar studies that can be found on non-pregnant populations that show the same thing. Now, when I say that e-cigarettes are safer than smoking cigarettes, that's kind of like a blanket overall statement. When you're looking at an individual person and trying to counsel on the individual rather than like the public health level, it's important to note that if somebody is able to stop smoking cigarettes entirely and only use a vape, that has been shown to improve pregnancy outcomes. We see longer pregnancies, less preterm birth. Not less preterm birth, because both groups in these studies had similar rates of preterm birth. But your pregnancy might be, 38 weeks and 5 days instead of 37 weeks and 6 days or something like that. So a few days still within the normal range. We also see increased birth weights, again, on a similar scale. Like all the babies are pretty much regular size, but this might be the difference between, 7.5 and 8 pounds, something like that. We don't see those same results for people that decrease the amount of cigarettes they smoke while transitioning to a vape. And that's important in the short term, but I want to also remember that we're thinking about the long term. So if someone is able to reduce the amount of cigarettes that they're using by using a vape, that's wonderful news. It could be the first step towards quitting nicotine entirely. And so we need to encourage people to make any positive change, no matter how small, even if we're not going to see improved outcomes in the short term. We got to keep that long game in mind. Anytime I talk about cigarettes, I want to mention Safe to Sleep. You may have heard of this campaign in the 90s, late 80s, I don't remember. When I was a baby, we started having this campaign to put babies on their backs to sleep. My parents and many generations before us had been putting babies to sleep on their tummies because it was thought that they sleep better that way. We found that after we started placing babies on their backs to sleep, our yearly deaths from sleep-related causes among infants went from 8,000 to 3,500. So it was quite a dramatic drop. So these interventions are effective for protecting people and keeping babies safer. We know that babies are at higher risk of a sleep-related death if they have a parent who uses cigarettes, if they have a parent who uses other substances, including alcohol, and if they have had a NICU stay. So that's 3 risk factors that a lot of the babies in our population share. So it's extra important for us to educate our clients about safe sleep. So the main parts of it are on their back, nothing extra in the bed, no hats, no mittens, no stuffed animals, nothing that could be a suffocation hazard. We want to avoid overheating. When we're too hot, it puts a strain on our breathing and on our heart, which can increase the risk that they will be overloaded. We want a flat, firm, tight sheet when we want them to be on their back again. If you are interested in getting a training and certification with continuing education credits, you can go to safe2sleep.allthoseletters.gov. It takes about an hour and a half. I've done it a couple times. Highly recommend for all people who work with anyone with a capacity for pregnancy. This is really important to keep our kiddos from dying. So to wrap up our nicotine and tobacco conversation, I want to point out that even though we have really strong evidence of just so many medical, long-term parent, child risks, we somehow manage to respond to tobacco and nicotine use during pregnancy with a harm reduction perspective in this country. We do tend to stigmatize people who use cigarettes during pregnancy, and that is not a good thing. But other than that, when somebody is pregnant and is using cigarettes, we advise them to quit or reduce. We encourage them to try different things. We offer medications, we offer therapies, we offer behavioral changes. We don't make assumptions about their parenting ability. We don't investigate their homes. We don't take away their children. We don't put them in jail. We don't force them into inpatient treatment. We don't report them to authorities. We promote the use of human milk because we know that breastfeeding and smoking cigarettes, or chest feeding or body feeding, if you're looking for some more words to describe that act, body feeding and smoking cigarettes is safer than formula feeding and smoking cigarettes. With other drugs and even sometimes with cigarettes, we tend to have this idea that we're going to tell people, no, you can't breastfeed while you use that drug because then they will breastfeed and not use that drug. But that's not the alternative for most folks. It's not provide human milk and use the drug or provide human milk and don't use the drug. It's provide human milk or use formula. That's the actual choice that we're looking at. And so that's what we need to consider in the risk-benefit analysis. Now, formula for babies is a life-saving invention, and I am super in favor of it. And I'm also super in favor of anybody who wants to provide human milk and to chest feed their baby. They should be able to do that. Chest feeding is a human right, both for the infant who has the right to that immunity and that bonding and that precious and unreplicable experience, and the pregnant and birthing person has that right as well. So we respond to tobacco and nicotine in a harm reduction manner, and we just need to start applying these same lenses to other drugs who have lower or less strong evidence of risk than tobacco and nicotine do. I want to point out before we wrap up that every harm reduction intervention that's ever been invented came from the minds of somebody who uses drugs. We take care of us. We are not out here waiting to be saved by SAMHSA or doctors or medical professionals or social services or the nonprofit industrial complex. We are the leaders in this movement, and we demand to be listened to. People who use drugs invented methadone, needle exchange, peer support. People who use drugs invented overdose prevention sites. People who use drugs have been giving out naloxone since when it was illegal to do so, because we understand that nobody's going to do this except us, and nobody knows how to do this better than us. So I encourage you all to be leaders in your spheres of influence and in your organizations. Here are just some practical referrals that you can use with your clients. Make sure that folks are signed up for women, infants, and children. You can sign up for this before you give birth. It gives you some like supplemental SNAP and stuff like that. Encourage all pregnant clients or even clients who are considering pregnancy to get in touch with a birth worker, also known as a doula. This is very similar to peer support in that doulas are stepping in to fill the gaps left by our failed medical system. So these are kind of like a professional auntie. So it's somebody who is very knowledgeable about childbirth, baby care, human milk, and they also can maybe do your dishes or run to 7-Eleven and get you a pack of cigarettes. This is a person who will support the birthing person and their family in whatever way is needed. Oftentimes as well, doulas are not mandated reporters, so that's a bonus. Help people out with lactation support. Lactation, of course, is kind of like the academic word for human milk provision. So LLLI.org, that's La Leche League International. La Leche League is one of the oldest and largest community support networks for people who are looking to breastfeed. And I really like them because they combine kind of support groups with other body feeding people with support from an internationally board certified lactation consultant, which is somebody who is extremely knowledgeable about the anatomy of the breast and how milk production works and what sorts of illnesses and problems can pop up. So it's really, really great to refer your folks to a local LLL organization because they will be getting both of those pieces, which are so necessary. Baby Cafe USA is another one. They do a lot of virtual support groups. And then check out postpartum.net. There's a lot of organizations that are supporting mental health in the postpartum period, Postpartum Support International. As it has become one of the leading causes of death in the maternal period, we're seeing a lot more attention being paid to mental health in this period as well. So very, very important to keep an eye on. And that is the end of the lecture part of this presentation. I can open it up to questions. If you want to get in contact with me later, I love corresponding with people, especially people who disagree with me. So like if you didn't like something I said, or if you want to challenge me and encourage me to grow and learn and maybe even change my mind, I would be super into that. That's it. How did I do? Okay, not bad.
Great presentation. It was very interesting. Will we be able to get a copy of the slides?
Do you have them, Casey?
Yes,
Okay, cool.
I can send those out to folks.
Okay,
Yeah.
great. Thank you.
I really enjoyed it. Thank you so much. It was very informative. I just have a question about like, what would you suggest in regards to finding out more about like the intersectional things that you definitely, centered, like for someone who's dealing with race or gender issues along with being pregnant, like are there any kind of recommendations or organizations that you can recommend?
Yeah, so as far as some of the race stuff, we have a little bit more like formal work on those issues. I'd recommend that you check out Movement for Family Power. They have a lot of resources about the racism inherent in the medical system, the racism inherent in the child services systems. And they also provide legal support for folks. And I think that's a huge part that we tend to neglect as we're caring for these folks, that so often they want like what you mentioned, they want to find other people that have identities similar to theirs, and they also people who have more layers of oppressed identities on top of each other tend to have less access to legal support. So that's why organizations like Movement for Family Power are really helpful. There's also Elephant Circle, National Advocates for Pregnant Women. Oh, excuse me, they changed their name. I got to remember, it's Pregnancy Justice now. Yay for inclusivity. PregnancyJusticeUS.org is their website. And those are places where you can find some of that support. As far as support for trans parents, It's a little bit more underground, frankly, because being a trans parent is more explicitly criminalized in many parts of this country. And when I say explicitly criminalized, what I mean is that being a trans parent is stigmatized and is a reason for people to watch you and to think that you're a bad parent, and it's basically criminalized without actually being criminalized, even in the parts of the country where there aren't laws explicitly about it. So I tend to see those support groups being more underground. I don't even honestly want to say them on this recorded presentation, but if you get at me on my email, which I think, is it at the top? Did I put it? Where is it? There it is. Okay, cool. Good job, Past Joelle. If you get at me via email, I can share some of those with you. There are some social media groups. There are some influencers that are trying to work on the issues of trans parenting. I don't know any organization other than ours that even attempts to talk about gender diverse parenting in the context of substance use, unfortunately. So a lot of times what we have to do when we're supporting people who use drugs is make recommendations to the best resources that exist, even though folks might find themselves stigmatized in those resources, which is similar to people who are trans parenting, right? Like, we have all these good resources, but they're going to misgender you over and over and over and over again. So I'd really love it if we could develop some kind of space where all of these identities are safe, but at this point, we don't really have an intersectional organization like that, so it's still kind of piecemeal.
Thank you so much. That was so rich, and I totally respect you really supporting the autonomy of a vulnerable access point, right? And I totally respect that you did that. So so thank you.
Yeah, but please email me. Like, I'm not keeping it a secret. I just, I don't want to put these folks on blast. I keep seeing things in the chat. Let me see. We're putting those links in there. Awesome. Well, if there's no more questions, what time are we at? I think now my screen's frozen. Oh well. I want everybody in this meeting right now to consider me a resource. Like, when I say reach out to me, I'm totally serious. It's not really a good attribute of mine, but like, if I get an email or a call or a text from somebody who is in the trenches, I tend to like drop whatever work I'm doing and just like write you a book and like give you all the resources I can find. I tend to kind of overdo that a little bit, but it's because I'm really excited and I want to talk with people, especially people who are working in peer support. Like, please let me be a resource to you if I can in any way.